Good morning. So I'm going to talk about something a little, I don't know that it's off topic. I would suggest it's not. It is part, as the overarching goal of our enterprise was expressed this morning, to gain a better understanding of the gun violence domain. I think my topic falls within that scope. I'm going to talk about the role generally of drug markets and homicide. I promised Greg that my results, in fact, are based on variance in gun homicide and not gun homicide. The criminologists here know quite well that drug market violence is profoundly gun-related. But for a number of reasons, I'm going to look at all homicides, and that will include non-gun as well as gun homicides. So I'm going to give you an overview, including the results, so that when I run out of time, you'll know the end of the story. There's been very little attention, either public or by the research community, on the connection between the opioid epidemic and homicide. Now, as a criminologist, that's significant, because I grew up during an era in which the crack epidemic was viewed as a profoundly important criminal justice problem, and there was a great deal of research on crack markets and how they contributed to lethal as well as non-lethal violence. Again, by the way, nearly all gun violence. That hasn't been the case with the opioid epidemic, and I'll go into why that might be in a bit. But one reason could be that the opioid epidemic has been disproportionately concentrated in the white population. And the crack cocaine epidemic, at least in its initial years, was concentrated in the African American population. Secondly, there's been no notable rise in the white homicide rate until 2015, the overall rate, though there are some interesting, I think compelling subnational variations that I'll go into. So, the case has been made for connecting illicit street drug markets to homicide. That case was made primarily during the era of the crack epidemic and the really explosive growth of research on crack cocaine markets, their criminal justice consequences. And what came out of that research, among many other things, and I don't know that we needed the research to point it out, is that street markets in illicit commodities, drugs in particular, are very risky social spaces. And I can think of no reason, nor can my colleague, by the way, Joel Wallman, who's the co-author on this paper, we couldn't think of any reason why, in principle, the opioid street markets should be immune to the violence dynamics that we now, I think, routinely assume is the case for crack cocaine markets. So, we did a state-level panel study during the course of the opioid epidemic. Typically, the epidemic is, the starting point is the latter part of the 20th century. The data we needed are through 2016 for the 50 states and the District of Columbia. Our outcomes are the total homicide rate, the white homicide rate, and that's the non-Hispanic white homicide rate, non-Hispanic black homicide rate, and the drug-related homicide rate that comes from the supplementary homicide reports. A number of predictors, most of which figure pretty routinely in models that predict homicide at the state and city level. The key independent variable of interest is the opioid death rate, which is our proxy for opioid demand, and I want to explain in a bit why we think that proxy makes sense, has some validity. And we use generalized least squares, panel models, corrected in various ways for our estimates. What do we find? We find significant effects of the opioid death rate on the white homicide rate and on the drug homicide rate. We find no effect on the black or African American homicide rate. with the other variables in the model controlled. We find contemporaneous effects, but we also find, and I have to be cautious here, we find a strong suspicion of lagged effects. And then, rather provocatively, I will acknowledge we attribute perhaps up to 20% of white homicides on average over that period, 99 through 2016, to the opioid epidemic. A lot of limitations, which I'll describe. But the most important one is that we know, compared to the knowledge of the drug markets during the crack cocaine era, and that knowledge came in the form of quantitative as well as extraordinarily rich and important qualitative research, we know next to nothing about the contemporary street markets for opioid. We do know that the use of opioids and the demand for opioids is far greater than the demand for crack cocaine ever was. And yet we know next to nothing about how the opioids are acquired other than through prescription. And then I'll draw some conclusions. So we have to measure opioid demand. That's difficult because the opioid death rate, which is the commonly used measure of the epidemic itself, and it's increased sevenfold over that period from 99 to 2016. Obviously, it confounds the prevalence of use with the lethality, the inherent harmfulness of the drugs used, especially heroin and fentanyl, compared with prescription opioids, right? And so we had to deal with that issue. We deal with it by showing that multiple indicators, including survey-based indicators, show a truly enormous rise in the prevalence of opioid use over this period. But because the confounding still concerned us, what we did as robustness checks was reproduce our analyses on the years prior to the big upsurge in heroin use and fentanyl use beginning in about 2011. So we reproduced the analysis on that earlier period, trying to remove some of the influence of these more inherently dangerous drugs. We also have a measure of police seizures of fentanyl sent to laboratories for analysis at the state level, and we use that as a control as well. So I'll talk about our results with the national trends, some state variation, our regression estimates, a bit about contemporaneous and possible lagged effects, and then how we arrived at this predicted impact on white homicide. There's the opioid death rate in blue from 99 to 2017. And as you can see, it does indeed increase exponentially. There's the total firearm homicide rate in the United States, which is relatively flat over this period until we get to 2015, and then we see, when I talk about homicide, I don't like to use the word modest, but there is a modest bump in the firearm homicide rate, no change in the non-firearm homicide rate, and that's the 9/11. I'm using data, the Uniform Crime Reports put out by the FBI, soon to be replaced, one hopes, with NIBRS, does not include the deaths resulting from the terrorist attack in 2001 as homicides. But the National Vital Statistics System, from which these data come, does classify those deaths as homicides. In any event, there's no apparent relationship on the face of it between the massive increase in that measure of the opioid epidemic and homicide rates overall. But there is intriguing state variation when you get to the subnational level. And indeed, somebody mentioned earlier, we really need to be at the sub-state level. I couldn't agree more. Problem is data sparseness and also mandatory data suppression by the NVSS, which makes anything below the state level pretty difficult for estimation purposes. But here are two states. There's the age-adjusted, and all these rates are age-adjusted, by the way, age-adjusted firearm homicides per 100,000 in the non-Hispanic white population over the course of the epidemic. In Ohio, where you see that there's a notable increase, and in the state of New York, where there's not. Ohio is one of several, more than several, a number of states in which homicide rates do bump up over time, although it's not apparent in the national rate until we get to 2015. But there is state variation. Forget about this. We'll let the discussant, if the discussant wants to. These are simply the regression results. Let me summarize the regression results for you. I find no significant effect of the opioid death rate on the total homicide rate with those other covariates in the model. I do find a significant effect for the drug homicide rate and the white homicide rate. These can be interpreted, the coefficients can be interpreted as elasticities. These are log-log models. And as you can then see, these coefficients, these effects, are pretty small. But their impact is not necessarily so small because of the enormous rise of the opioid death rate. I'm happy to talk about the impact of the effects of other variables and other intricacies in the models, but let me move on from that, in this context, rather silly slide. We do know something about the use pattern with opioids. Typically, the typical pattern is an individual will start using opioids or abusing them with his or her own prescription, or make use of the prescription medications of family or friends. Some number of users then, when those first-hand sources of supply run out, some number of users, and we don't know the fraction of users, move into the street markets. Once there, many learn that on a dose-for-dose basis, heroin is cheaper and certainly more potent than the synthetics, except for fentanyl, which comes onto the scene in a big way after 2013. And these days, most heroin acquired on the streets is laced to one degree or another with fentanyl. And indeed, other drugs, methamphetamine and cocaine, also now found to be laced with fentanyl. Fentanyl, a very, very powerful opioid. Some moved to the street markets. We don't know how many. But there's every indication that the street drug markets have expanded during the opioid epidemic. Given the fact that there is this transition period from personal use to move into, for some users, moving into the street markets, we suspected there might be a lagged effect on homicide rate. When we inspected the data, it turned out that a 2-year lag maximized the effect. And when we use that 2-year lag, we find that on the white homicide rate, the coefficient doubles in size. For the drug-related homicide rate, there's no difference, but we didn't expect a difference because for drug-related homicides, there should be no lag in each instance, whether we're measuring all homicides or measuring just drug-related. At a 2-year lag, we're looking at drug-related homicides. That's our surmisal, but I have to say these lagged effects, which we don't make a lot of in the paper, are built on speculation about how we think, and we think our assumptions are sensible, how we think these markets are operating, absent the kind of research we need. So, how did we do the impact assessment? We essentially asked this question. What if there had been no opioid epidemic? And how many homicides would have been averted. And to be conservative, remove the influence of outliers, we looked at the range from the 25th to the 75th percentile of the opioid death rate. We made our predictions of the number of homicides, the counts at each point, at the interquartile range, all other variables at their means. And it turns out that, roughly speaking, about 1,000 homicides on average per year could be attributed to the opioid death rate, based on that, and I would argue, relatively conservative assumption. A little over 5,000 white homicides on average per year, that's where our 20% comes from. I don't want to hang my hat on that prediction. It's a conservative estimate, though interestingly, if we use the min and the max, the endpoints of the distribution, the results are really very similar. So, data suppression makes it, from our point of view, impossible to generate reliable estimates of Hispanic homicide that might be associated with the opioid epidemic. And our results for the non-Hispanic black homicide rates are somewhat uncertain as well, because in those models we had to use the total opioid death rate as our predictor, because the non-Hispanic black opioid death rate, due to data suppression and small black populations in many states, made the black opioid death rate data simply unreliable due to missing data. We need area-specific survey measures of opioid use to get around this confounding of use with the inherent harmfulness of the drugs used. But especially, we need to learn a whole lot more than we currently know about the street opioid markets. This problem, the opioid epidemic, has, I think, quite correctly, and in sharp contrast to the crack cocaine era, been defined as a public health crisis, over and above a law enforcement or criminal justice crisis. Absolutely true. Now, why the change in emphasis or perspective over that period? I think it's undeniable that the fact that this crisis is centered to some degree in the white population has caused a shift in perspective from criminal justice to public health. It's also the case, however, that our views of drug policy may have evolved somewhat over time. And finally, opioids do have a legitimate medical use. And from that perspective, I suppose it's not surprising one might define the opioid problem as a public health as opposed to a criminal justice problem. So we argue that we should retain the public health response to the opioid epidemic. There's no evidence that mass incarceration, mass arrest and mass incarceration blunted the crack cocaine epidemic. If anything, the evidence suggests quite the opposite. Mass incarceration pulled adult drug dealers off the streets without any diminution in demand. Younger people with reduced legal liability took their place in the urban crack markets. They were armed, and we had a spiraling arms race in the inner cities as a result. I don't think we want to go back there. I do think expanded treatment is the approach to take. It's also, I think, important, but only as a first step, and one that's, I think, should be more carefully thought out than it is, to regulate the legitimate sources of supply, as we're doing now. Greater regulations on insurance companies that are in turn imposed on physicians and pharmacies, both federal, state, and local, to reduce the legitimate supply of opioids. The problem is that if demand for opioids is not reduced correspondingly, that will simply enlarge the street drug markets and the violence associated with street drug markets. So while we hear about important cases in Oklahoma and elsewhere in which the drug companies now are being faced with huge fines, good. They did, in fact, start the crisis. But we have to be very careful about any actions we would take that would expand the black market in opioids. And then finally, we need to recall the Case and Deaton research and other attention that's being paid to sources of despair, as Case and Deaton put it, especially in small towns, in rural areas, especially in the Midwest, Ohio being only one example, that I think it's fair to say play an important role in the rise in opioid abuse, in the rise of suicide, and also now we believe in the rise in those places, at least partially, in homicide. Thank you.